Boa noite, sejam muito bem-vindos a mais um Caminho Sem Dor. Dessa vez um Caminho Sem Dor especial com o professor Philip Peng, direto de Toronto. O professor Philip Peng dispensa apresentações, é uma referência, principalmente na medicina intervencionista guiada por ultrassonografia, e nos dá a honra de poder participar aqui do Caminho Sem Dor, com a moderação do professor Charles de Oliveira. O professor Charles de Oliveira, junto com o Fabrício, os primeiros FIPs do Brasil, né, prof? E ele que vai fazer a moderação desse Caminho Sem Dor especial. Hoje o Caminho Sem Dor ao vivo é somente para os alunos do SIMPEM. Amanhã, dia 5, estará disponível no YouTube do Caminho Sem Dor para todos os médicos e profissionais de saúde que queiram acompanhar a evolução e o que há de novo em ultrassonografia. Hoje o tema da aula é anatomia e sonoanatomia para procedimentos em ombro. Bem-vindo ao professor Philip Peng, bem-vindo ao professor Charles. A moderação agora é com você, professor Charles. Está sem som, professor?
Pessoal, boa noite. Satisfação estar com vocês todos aqui. E primeira coisa é que essa aula seria amanhã. E por um pedido do professor Peng, amanhã ele tem um jogo de basquete do Toronto Raptors. E aí ele pediu para antecipá-la para o dia de hoje. Sendo assim, a gente vai fazer os primeiros 17 minutos. É uma aula gravada que ele mandou para a gente e ele vai entrar ao vivo para fazer aquele bate-papo tradicional. Eu gostaria que essa participação fosse ativa, né, de todo mundo, e que na hora das perguntas, a maior parte das pessoas que puderem abrir a câmera seria bastante interessante. Afinal de contas, interagir com sonomes é um tanto difícil, né? Pelo menos para mim, eu acho assim. Eu acho que ele também. Então é isso aí, Carlão. Vamos soltar, dar o play aí e vamos embora.
Prof, se der algum problema no som, você me chama, tá?
Tá bom.
Anatomy, sonoanatomy, and procedures of the shoulder. This is my disclosure slide, and a lot of those information and pictures are coming from these two books. And there's also a very good reference from this iBook, in which there's a lot of a video that I reference in this lecture. I will cover the scanning protocol for the shoulder examination with ultrasound, and I will talk about some specific interventions for various structures for shoulder pain. The 4 areas I will cover is the long Hip Bicep tendon, the rotator cuff, the Glenohumeral joint, and the AC joint. But I will not talk about the calcified tendonitis, the sonoanatomy and the management, and I also will not talk about innervation and denervation of the shoulder. There's a good reference here, published in 2011, on the basic anatomy and sonoanatomy of the shoulder. Most of the protocol I'm going to use is the one that followed the European Society of Musculoskeletal Radiology suggestion. First one is a long hip bicep. One of the important anatomy of this is that it's situated between the greater tuberosity and lesser tuberosity. And covering this is the bicep muscle and also the transverse humeral ligament, which basically is an extension of the subscapularis tendon. A beautiful sonoanatomy here. So one of the important part of the position is we call give me the money sign. So make sure that the arm is in a neutral position. You can see the greater tuberosity, and the lesser tuberosity on the middle side is more sharp and pointy. You can see a long hip bicep tendon, which is very anisotrophic. Anisotrophic means actually by tilting a little bit angle, the tendon will look from hyperechoic to hypoechoic. And then you can see the transverse humeral ligament and the delta muscle superficially. If you Doppler the area, you will see a ascending branch of anterior circumflex artery, which usually on the medial side, but it can have a variation. It can be on the lateral side. The long axis of this tendon is important because we want to follow up and see any tear, especially in the myotendinous junction. Now, the primary pathology of this is uncommon. Most of the time because it's an innocent bystander, because of the intra-articular and extra-articular cause between the rotator cuff and the labrum. So it's related to the rotator cuff disease, or that we call SLAP, the superior labrum anterior posterior lesion. And the second implication, because of this unique intra-articular cause, it dragged the synovium with an extra-synovial extension here, extra-articular synovial extension here. That means that it can be an axis, the rotator cuff interval, that means where the long hip bicep situated, can be an axis to the intra-articular compartment. And we'll talk about this in a moment. How to scan the rotator cuff interval to get to the synovial extension. This is where you find the bicipital groove, but going it more in a cephalic position and tilt it, we can go to this rotator cuff interval, which is supraspinatus and subscapularis, and in between this is this. Here you can see the subscapularis tendon on the middle side, on the lateral side, supraspinatus tendon. The humeral head will become a bit flat rather than the bicipital groove with a groove pattern. And here is a coracohumeral ligament. You may not see here, there will be a superior glenohumeral ligament, which because of the orientation, you won't be able to see. Just give you a diagram that I create. So this is a rotator cuff interval that between the two muscle, and the superior glenohumeral ligament is basically flat in a various position. Because of the orientation, you won't be able to see in ultrasound. All right, what are the interventions? So it's very simple. I usually do our plane for the long hip bicep. Just put it over the bicipital groove, put the needle in the peritendon as a peritendinous injection. 3 mm will be more than enough. It's a diagram to show this is the bicipital groove, medial, lateral. There's a tendon here. I just put the needle over plane. You can see here, my injection is deep to the transverse humeral ligament there. Obviously, I use a Doppler to make sure that I'm not injecting into the vessel or close to the vessel. Rotator cuff. All right, so the most important, well, there's 4 of them. The most important one is still the supraspinatus. Let's talk about subscapularis. When you scan in this, give me the money sign. Give me the money sign. Just a little bit medial to the lesser tuberosity. You can see the subscapularis tendon, and you can external rotate and drag the subscapularis tendon. And then you can see here, you can actually make it even longer. And when you put the ultrasound probe in the short axis of the subscapularis tendon, you will see a funny pattern close to the bone. It's not something that reflecting the tear, but is reflecting the myotendinous junction with alternate tendon, muscle pattern. Now, when we scan the supraspinatus, just make sure that you use a reference point of the bicep tendon, long hip bicep, because usually within 1.5 centimeter in general is still the muscle fiber from all the tendon from the supraspinatus tendon. When you're scanning too far away from the bicep tendon, you are basically seeing the infraspinatus. All right, this is important. So this is actually an example. You are scanning here, apparently okay, but the bicipital groove is here, so you're scanning a little bit further away. You are actually looking at the infraspinatus. So when you are scanning a little bit more medially, you see here, you see a delta muscle, acromion. So subdeltoid bursa will be a hypoechoic area. So this is the fascia from the deltoid. This is the tendon, supraspinatus, and between this two structure, the hypoechoic structure is the subacromial bursa. So you can do a dynamic scan. I usually do put the ultrasound probe and have the arm abduct. And this acromion, this you can see the supraspinatus tendon, go in and out, and I can scan, put my probe over the acromion to see this, or I can put it over the coracoacromial ligament, which also part of the area where the impingement can occur. We can show this in the live demonstration. I like this, we call the modified CRASS, C-R-A-S-S, modified CRASS position. So remember, you give me the money sign. Now, once you have a money, you put it in the back pocket. So when you put the money in the back pocket, this is the position we call modified CRASS. What does it mean? It really achieves two things. One, it drags the supraspinatus tendon more outward. The second thing is you actually causing an internal rotation of the humerus. So what is important? Because when you drag it outside, you can appreciate a longer portion of the supraspinatus tendon, medial lateral, and also in the short axis and long axis. And again, you can see the bursa as well. And because it rotates medial, more internal rotation, so you need to scan more anterior position. All right, let's quickly just go to infraspinatus and teres minor. Recognizing the scapular spine is important, so that the muscle just inferior to the scapular spine is the infraspinatus. If you do the short axis here, and then you can see another muscle pattern, which is the teres minor there. And when you actually scan closer to the humeral bone, you can see a ridge, and then you can easily differentiate the infraspinatus and teres minor. All right, so how to do a subacromial bursa injection? By far is the largest bursa in the body. We use it because a lot of impingement syndrome, from whatever reason, causing a painful arch, and is a very effective in terms of as an adjunct to the physical therapy. The injection is very simple. You just actually you can do in plane, and actually between the deltoid and supraspinatus, and you do out of plane when someone who have a very waist deltoid, very skinny, it may be easy to use out of plane. So still the in plane, but in the probe in the transverse manner. There's a video to show when you are when you inject just a tiny 0.5 cc and just like this. Because if you are injecting into the bursa, there's no resistance. The local anesthetic will just spread like this. Now, there's one situation, so when you are in the deltoid or in the tendon, you won't, that you are in bad shape. Your local anesthetic won't just spread freely. There's a situation when you have a rotator cuff disease, the bursa may be a little bit sticky, and you inject, it may not spread really well. So then when you inject, you just have to keep open, and advance the needle to open all the subacromial space. All right, glenohumeral joint. In the past, one of my favorite approach is the posterior. I have a patient lying in the lateral position. I tried in the sitting position before, but then the patient just pass out expression man for some reason. So I just keep them comfortable. Just do it in a lateral position. You just put the ultrasound probe just inferior to the scapular spine. And here is a lateral, is a medial. You see beautifully, there's a glenoid, humeral head. You can see the cartilage. You can see the deltoid and infraspinatus, the tendon here. And this is the labrum. And the needle need to advance just deep to the tip of the labrum. And there's some tips about injection. We'll go through this in the workshop. If you scan from the same scan just a little bit more medial, you will encounter something very interesting. So there's the same scan that you saw, but there's a glenoid, humeral head. But more medial, you see a sphenoglenoid notch where the superscapular nerve will start to go to the infrascapular fossa, and this is actually a sphenoglenoid notch. The common indication for adhesive capsulitis, and you can use it for glenohumeral joint osteoarthritis. For the injection, there's a video, so this the humeral head, the labrum. I put the needle just deep to the tip of the labrum. You can see when you inject, it just actually contained within there, and the medication will go inside the joint. So that's why you don't see the medication accumulate. I have to say my favorite injection now for the adhesive capsulitis is called rotator cuff interval injection. Remember, we talked about rotator cuff interval, which is between the long half of bicep, sandwich between the subscapularis and the supraspinatus. And here is access to the joint. If you inject in the synovium, it can access to the joint space. We have an article coming out, and what is so important is that when we inject, I like to inject from the lateral to medial because there's less chance you encounter the superior glenohumeral ligament. So this is the rotator cuff interval here. When you inject here, so what it means is it inject into the joint, but also it spread to the periarticular area. And what we find in the literature, there is a few RCTs to show that this is better than the posterior approach for the adhesive capsulitis because our anatomy studies show that it spread to the pericapsular disease, pericapsular structure much better, which is the important area or structure of pathophysiology for the adhesive capsulitis. Again, we will talk a little bit more in the workshop. AC joint. Now, AC joint is here, so it's very simple. You put the probe over the AC, acromion, and clavicular, and you will see this. So here, typically, you see the meniscus, but I would say when you get older and older, the meniscus will be worn and tear, you may not see it. So it really depends on the age and the healthiness of the patient. And I just want to tell you one thing. When you look at the clavicle, people say this is follow the clavicle, and just actually is yeah. So you follow clavicle and then go to acromion. You put the probe there, and you see nothing. You see nothing. There's a typical error when someone who knows wise and or faculty don't know what they are talking about. So I just want to just let you know it's an S shape. The clavicle is S shape. So when you go here and when you scan here, you see nothing because it turned out S shape. You need to go here and rotate back. Then you can see a beautiful area. So when we see this structure, what you have to do is just put a needle there. So there's three things I want to remind you. One is the joint is very shallow, very shallow. And when you puff through the joint, I think no more than 1 centimeter, and you should not go more than 1 centimeter when you puff through the joint out of plane, because the joint is very shallow, and deep to this is the supraspinatus. And you can see here is actually part of the subacromial bursa. Now, although you can say, well, I can put the needle there and inject into subacromial bursa, but this is not your point. Your point is you want to inject into the joint. So you can see this is when you have a needle, you are there. Even out of plane, you can see the shadow, you can inject. And here again is the outside of the joint. So you want to have a needle inside, not outside the joint, and this is supraspinatus. Sometimes people say it's a little bit hard. Well, I can give you tips how to do it easily. Again, it's a 1 second injection, but I will show you in the workshop. But some people just complain it's difficult and do the long axis, short axis scan. So remember, I just showed you there's a long axis scan here, which you show the AC joint, but you can do the we call long axis scan, short axis scan. Sorry, short axis scan. How do you do it? You scan over a joint like this, and then move to the clavicle, move to acromion. So how does it look like? This is the joint, which this is the acromion, and when you are inside the joint, you see nothing there. You see actually nothing there. Let me just go through this again. Sorry, it's so fast. This is the joint, the AC joint. Now I'm on the clavicular side. Then there's a joint again, and now I'm on the acromion side. So what you have to do is you toggle in the short axis on a joint, which basically you can see through, and you can toggle over the clavicle, which is a round structure. You toggle to the acromion, which is a flat structure. By doing this, you see the joint space here, and then you can put the needle in plane anterior to posterior. So again, I will show you in the workshop. But here is just give you some principle anatomy, sonoanatomy, some concept about how to do the injection. Certainly will entertain you more in the workshop.
Thank you very much.
Liga o som, Charles.
Ativo. Pessoal, Dr. Peng, are you there? Yes. Pessoal, vamos abrir a câmera, quem puder, e, se possível, né, vamos interagir com o Dr. Peng. Dr. Peng, first of all, thank you very much for you share your time with us. And you are an idol for the Brazilians because you have a lot of knowledge and is a very good teacher, as you know. My first question, please do some introduction yourself before I'll do my first question.
Well, Aula, I hope this will be one of my few virtual lecture. I cannot wait. I hope one day I will come back to Brazil and just talk to all of you, give you a lecture or workshop in person. The shoulder, I have a lot of interest in the shoulder, especially if there's a lot of new procedures I can do. But one of the key is not just the ultrasound, but physical examination, good history, physical examination. Then I use my ultrasound as a stethoscope to diagnose to confirm what I suspect. And from there, then I formulate a plan. I just want to let you know, yes, the one I just showed you is a basic intervention, basic. But it doesn't work in a lot of patients. Think about this, those with a lot of advanced rotator cuff disease, those with advanced glenohumeral joint. You try all this, have been well described in the textbook. I would say a lot of those have been tried and sent to my clinic. I have a specialized clinic. Then in case they fail auto injection and they don't want to have a surgery, you are really stuck. And I think that the second step is we develop some new procedures, how to, we call the denervation of the rotator cuff sensation and also the glenohumeral joint sensation. This will be a game changer in the future. So what I just showed you is a very basic intervention. Everyone talk about this. Everyone talk about this. But I hope one day when I come to São Paulo or some part of Brazil, I can share with you some of the new technique. When you have someone with advanced disease, you just don't know what to do. And I have to say, with the new understanding, the new treatment is very gratifying. We can have those who really have a lot of advanced disease. So just a brief, I don't want to keep it too long. And so if any question you can ask me, more than happy to answer the question. But sometimes I will ask you back some question as well. I love to examine and ask people a question.
Dr. Peng, my first question, how started this partnership between you, Trump, and Dr. Agur? Tell us about the history.
Dr.
Trump, the anatomist, Agur, and you.
Oh, okay. Okay, so it starts with, I don't sleep a lot. That's a problem. So when I sleep, sometimes I have a dream. So 7 years ago, I have a dream. And it is real because in my key lecture for my journal, what I told you that I have a dream. I saw a lot of people with a lot of pain in the joint, hip, knee, and shoulder. And typically when you're hip, knee, and shoulder, you do the simple hip injection, knee injection, and shoulder injection. That's like what I show you. The problem is when you get more famous, you get a lot of patients who are not responding to those simple injections. What are we going to do? So then suddenly I realized in my dream, can we change approach? Instead of putting steroid and local anesthetic, steroid and local anesthetic, and steroid and local anesthetic, that's the only thing we have. Can we find out the innovation and can stop the sensation, the pain sensation? That's why 7 years ago, we were on a mission. We look at the innovation of the hip joint, knee joint, shoulder, and then we are working on the wrist. Actually, it's a smoke and fire right now. We do a lot for the wrist. Next year, we dedicate for the ankle. And also, actually, something that you may not know, we are working very hard on coccyx and also lumbar medial branch. The lumbar medial branch, I hope that I don't jinx it. In probably the end of, sometimes in May, it will come out. We challenge all the conventional wisdom that Nikolai Bodog have done. Remember lumbar medial branch? You all do, everyone know about this. But this is a 50 years old knowledge. And everyone talk about this, but there is some inaccuracy about this. So so when we go there, we would talk about this. So our lab never stop asking questions. So what Charles asked is, John Trang is my PhD student. Now he's a PhD. And Aga is an anatomist. So three of us, we've been working very closely and look at every single possibility to contribute to a better clinical care, because a lot of patients with advanced musculoskeletal disease, they are stuck. It just actually we need some another stage, higher stage, to provide better care.
Nice. Eu queria perguntar a alguém se quer fazer alguma pergunta, senão eu tenho minhas perguntas aqui. Alguém se habilita?
Eu gostaria de fazer uma pergunta.
Manda em inglês aí, Paulão.
Tá, vamos tentar. It's very nice to talk with you, Mr. Peng. It's an honor for me. I would like to know, when you are talking about the rotator interval, you communicate with the joint. There is some difference between put the drugs in the interval rotator or from behind in the glenohumeral joint?
So first of all, this is an excellent question. Second, for those who don't know, so what's your name, by the way? Oh, okay, let me, Paulo. I did not pay him to ask me this question. It's an excellent question. So let me just give you just 1 minute of a summary. The joint, the glenohumeral joint can be approached. You stick a needle on the back, we call posterior approach. You can stick a needle from the front, that's anterior approach, which is very difficult because it's deep. The third one is through the rotator cuff interval. And somewhere along the long hip bicep, you can access into the joint. And turn out that this is very popular. Okay, fine. So, but then there is a problem. By far, the commonest indication for joint injection in shoulder is adhesive capsulitis, frozen shoulder. So we find that there's a free RCT, three of them, published in the last 5 years. There's a free randomized controlled trial. And for some reason, that injection on the back compared with the rotator cuff interval, the rotator cuff interval is much better. So we don't know why. Well, I'm going to tell you why. So we want to ask the question, and we find it. So first of all, this is the question mark, but we know that it's better with rotator cuff interval. Second, in the last 15 years, the understanding, if I ask you, what is frozen shoulder or adhesive capsulitis? Most of people think about, there's some stiffness, some fibrosis inside the joint. That's why you crack it. This is the common understanding, but proved not to be true. Most of the problem now we know is related to the adhesion around the coracohumeral ligament and somewhere around the rotator cuff interval. So instead of something wrong inside the joint, actually is when the socket moves, there's a lot of acromion ligament, coracohumeral ligament, and glenohumeral ligament. They are all stuck together. I can tell you, and it's very true, I have frozen shoulder myself, left and right. And what I have is I just have an AC joint problem because I just do a lot of those lifting, swimming. Actually, by the way, after this talk, I'm going to swim again. So I do a lot of swimming. I have a very terrible AC joint. But AC joint causing me frozen shoulder. You can get a why. So because frozen shoulder is not the intra-articular, it's not the intra-articular, it's periarticular. So it's a second thing. So that's why we did a study and find this. So let me just summarize. We know that the rotator cuff interval is better than the posterior injection for adhesive capsulitis. This is we know. We also know in the last 15 years, the pathophysiology is more around the roof, the pericapsular. So when we did the injection study, we were just amazed that the rotator cuff interval, when we inject, that get all inside the joint, but it also spill out to the pericapsular. But there's a catch. So the rotator cuff interval, you can inject from lateral to medial or medial to lateral. When you inject medial to lateral, that is a problem because there is a structure that you can't see. In ultrasound, you need to know something you cannot see doesn't mean it doesn't exist. So on the medial side, there's a structure you cannot see. It's called superior glenohumeral ligament. You cannot see, but it's there. So when you inject from medial to lateral, a lot of time you stick into the ligament. So limit the spread. But when you inject from lateral to medial, it go inside the joint 100%. It also go around the capsule. So now we complete the whole story. That is the thing unknown. Turn out that rotator cuff interval, it go into the joint, but spill to the pericapsular around the coracohumeral ligament, around the superior, middle, and inferior glenohumeral ligament, around the coracoacromial ligament, and basically lubricate the area. And that's why it's much more effective for adhesive capsulitis. So it's a good question. We don't know much in the past, but we work on this. I think we know more and more in the future.
Próxima pergunta, quem se candidata?
Sorry?
No, I'm talking to the audience. The next question. Alguém quer ter uma pergunta aí pronta? Se não, eu faço a minha. Dr. Peng, my question is, we know to do the denervation of the shoulder, we have 4 main nerves, the superscapular, subscapular, axillar, and the next one.
Left to subscapularis, lateral pectoral.
Yes, lateral pectoral. My question, to the target to arrive in the subscapular nerve, is it possible to do it guided by ultrasound or just with fluoroscopy? What can you tell us?
So just want to clarify. People look at me and say, I'm an ultrasound person. So I'm not just an ultrasound. I do half ultrasound, half X-ray. And because I do a lot of ultrasound, I would say if I think it's crazy, I will not do ultrasound. For example, when I do caudal, I will not use ultrasound. I will use X-ray. When I do lumbar medial branch, I can do ultrasound, but I will do X-ray. So let me get very strict. I will not just because I can do ultrasound better than other people, I will keep saying ultrasound. One thing is, let me just tell you a bit long story. Make it just 1 minute. The superscapular nerve, I made a mistake. The early publication, I find a few targets. I find it's sexy, it's great. I published that one. Then one thing I realized, when you want to burn a nerve, the radiofrequency ablation is designed to burn those tiny little branches. So if you have a nerve, something you can see, like what 2 millimeter, 3 millimeter, it's very hard to burn. You can block them, you can inject local anesthetic, but you cannot burn them. They just survive. So this is important. So for those who in Brazil, you all look very young, energetic. So I feel like I'm the oldest in this group. But do you know there's a doctor from Budapest called Egi Stoskizik? She come to Brazil quite often. So we have been working together, and we find there is something very simple. The target should be, the keyword is P-E-N-G. Somehow it's my name, P-E-N-G. So the key is you cannot target the nerve, the suprascapular nerve. You target the branches. So there are two targets on the supraspinous fossa, is in the superior glenoid. So one is lateral to the scapular notch. The other is just on the superior posterior notch, superior posterior glenoid. And then the posterior glenoid, you have make two targets. So if you block four parts of the glenoid, you basically burn all the suprascapular nerve instead of burning the nerve itself. Now, then tell me, what is the best way to find this? An easy way, I would say ultrasound, in my opinion. For those who have done X-ray guided suprascapular notch, you find actually sometimes you have a teal and the patient move a little bit, and you may not easily see this. And also the superior glenoid, you have a teal all the way to avoid the acromion. If you use ultrasound, like this, easy. So I would say that is again just like I keep on saying this. There's an article coming, hopefully by May, that about this technique. This is really a game changer. Even for me, I have a main mistake because I find a lot of space to burn the suprascapular nerve. Just understanding the suprascapular nerve is big. I have to target all the way to the very nerve ending. So this technique is called pericapsular nerve group block, or called a Peng block for the shoulder. So it just around the shoulder joint, and that's it. So I think ultrasound will be a better way.
I open for the people. Alguma pergunta?
You can ask me question in Portuguese, and then the Charles can explain or interpret.
Yes, I have many friends that have a better English than mine, and then can help me. Professor, when I am doing the procedure to the suprascapular nerve, you know, it's a deep structure. What do you prefer to do? Out of plane or in plane?
That's the reason why, Charles, I want to come to Brazil. No, I can show you 1 second technique to find a nerve. I can show you 5 second technique to get to the nerve. You are not alone. You are not alone. So somehow I just work with the juniors, so with my fellow, and I have a way to find the nerve in 1 second. You don't believe me? Invite me. Invite me to come. I'll show you 1 second technique to find the suprascapular nerve, and find you the 5 second technique to get the needle. So I usually do it with the in plane for lateral, for medial to lateral. So for those, one of the observer called Tamaris Solaris. So I don't know if she's here. She came to as an observer. She's going to be our fellow in July. I show her. So basically, if you want to scan it in 1 second, you just use the surface landmark. It's difficult for me to show it to you, but I can tell you 1 second. The reason why you say it's hard to get the needle, if you have a very big person, you use the curve, but what you have to do is, one of the bad habits, I'm not saying you, Charles, I know you're very senior, I'm just saying a lot of people have a habit. Once you put a needle and just look at the monitor and do this. No, to get it in 5 seconds, you don't look at the monitor. You look at the patient, the probe, with an imaginary plane. You put a needle for probably 2 to 3 centimeters, and then you look at the monitor. The needle is there. Now, one thing is the precision. The precision of the superscapular nerve are so accommodating. You're off a little bit. So basically, if you want to be so most of the time you want to put in a nerve you like this. In superscapular nerve is the floor. So you have probably 2 centimeters of those target. So even though you're off, as far as you inject within that 2 centimeters of we call the expansion between the floor and the supraspinatus, you will get it. So you see how easy it is. So I would say, I'd love to be with you right now, show you the 1 second technique for the scan and 5 seconds technique to put a needle. And I'm more than willing to work with someone who never put a needle in superscapular nerve. I will make it work for you.
Ô, Marcos André, cadê sua pergunta aí? Já está na hora sua aí. Professor, pode ir quem está falando?
Sou eu. I have a question, Dr. Peng. Thank you for the lecture. I'd like to know whether you see any role for pheno blocks in the shoulder for pain.
At the present time, not yet. And I know in St. Paulo, one of your colleague, Dr. Hassam.
Leonardo. Leo Ferrari.
No, it's Hassam
Ashami.
Yeah, Ashami. So he have a master's student called Nato something. I can't remember. Nato is the last name. So he is working on this is a master thesis, and we work together. But let me put it in perspective. There is 2. So alcohol versus chemical ablation versus non-chemical ablation. We can always say we can, but there's 2 things to consider. The other one is the context. The other is the margin. So what does it mean? In general, when you want to put it in the chemical, you want to be in a space that can be spread, is a large space to spread. And even though you spread a little bit wrong, nothing to worry about. So one good example is the hip, the articular branches between the psoas and the pubic bone. Huge space, let it spread. The femoral nerve is on the other side of the muscle, so there's nothing wrong. The other example is the knee. The articular branches are deep to the vastus medialis lateralis muscle, and it's large. You inject something, all the major nerves are far away. There's nothing wrong. So that is a good model. Say for static, will you put chemical ablation for cervical sympathetic chain or static? Will you do that? So why? Tell me why. So the reason why you don't, because of the context and the margin. The context is a tight space, and the margin, there's a lot of important structure around. Okay, so with the context and margin, you think about the shoulder. What is the context and margin? So if you put it in the superscapular nerve, in the fossa, it's possible. It's possible because there's a big piece of muscle, there's a bone, there's a big nerve, you can do this. But this is a true nerve that have sensory and motor. So you damage the area. So you don't want to do this. Unlike the hip and knee is all articular branches. So having said that, it's not the end of the world. So now, because we find a small area around the glenoid, called around the glenoid superior and posterior, if you are very good and inject a small amount, it's possible. I haven't done it. I think someone is thinking about this, have that idea. And basically all my idea on chemical is either in Hong Kong or Sao Paulo. So eventually someone will do it, and more than happy if you are thinking about this, I can show you the secret, the tiny little spot, you can put a chemical there. It's possible, but I haven't actually done those shoulder yet, but it's a concept is developing. Are you thinking about doing this, or you have done this already?
I have already. For knee.
For the okay, for knee, yes. Yeah, Leo already published, we do, actually, I would say 95% of my knee osteoarthritis, I do with chemical. So much faster, much easier, chop, 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 and that's it, yeah.
Thank you.
Próxima pergunta.
Professor, can I make a question?
Oh, yes, I'm here. So, yes, I'm here too.
Só identifica quem está falando, só para a gente saber também.
I am Pedro. I'm fellow from the Singular. Professor, we recently consulted a patient with acromion in the shoulder.
With what, sorry?
Acromion is a anatomical malformation of the acromion.
Okay.
So he arrived complaining of shoulder pain, and we chose to do a diagnosis block of the acromial branches of lateral pectoral and superscapular acromial branches. And he got better at the moment, and after that we planned hydrofrequency ablation only for the acromion. So I will ask you, what's your experience with the malformation of the acromion, and if the choice of the nervation of the solely the acromial branch was a good one or not?
Good question. So what you talk about is acromion. So basically, it's almost look like a fracture, but because of it's a two ossification center. So so it looked like your acromion looked like there's a fracture, but turned out to be two bone. Is it the one you're talking about?
Yeah.
Yeah. So that's called acromion. So let me just summarize just in 1 minute the thing you need to know. So the acromion are supplied by the top nerve. The top nerve. So think about this is a circle. The circle, the one above, is mainly by the superscapular nerve and the lateral pectoral nerve. That's number one. And the superscapular nerve, there is an actual acromial branch that purely go to acromion. So that's important. So that one, you need to know that is lateral to the scapular notch. You need to find this. If you don't, come to Toronto, or invite me to come to Brazil, I will show you. And the lateral pectoral branch is easy to find. There's one thing. So number one, you have the anatomical understanding. What supply is the acromial and the superior branch of the superscapular nerve. So in simultaneous, basically, all the branch in the supraspinous fossa, and then the lateral pectoral nerve. So, and then there is a histochemical understanding. So what is histochemical understanding? So turn out that there is an article published by the French group of orthopedic surgeon. Again, I'm more than happy to share with you. The innervation, there's two types. One is the nociceptive fiber transmitting the pain. The other is mechanical receptor. So what happened is most of the bottom sensation, you still have a lot of nerve around, but they are more mechanical, respond for the stretch. So makes sense because usually it's very lax in the underarm. Only when you stretch, then you have a bit of a tightness. But most of the nociceptive fiber is on the top half. So when you have this, it can be very painful. And that's the reason why rotator cuff disease can be very painful, because they are densely innervated by the nociceptive fiber. So if you have this and you want to do the deinnervation, so my suggestion is you can do cryo, you can do radiofrequency ablation. You target number one for free nerve. Number one, just lateral to the notch, put the needle there. That is the acromion branch. And then the second one is the posterior superior glenoid. Also in the supraspinous fossa, you basically just pretending you're trying to find the superscapular nerve, slightly more lateral. Then suddenly you see something like this. That's the glenoid. I'm more than happy to send you some pictures. And then the third is the lateral pectoral nerve. Do you know how to target the lateral pectoral nerve?
Yeah.
Okay. Well, since you are so confident, let me ask you a question. What artery? No, nothing you can't handle. Well, when Charles came to ASLA for exam, I love to ask Charles some question, and that's why we like each other. So, yeah, what artery that accompany the lateral pectoral nerve?
It's a branch of the thoracoacromial artery. Yeah.
And what's the name of that?
It's I don't know, the pectoral branch of the thoracoacromial.
So it's called the acromial branch of the thoracoacromial artery from the first division of the subclavian artery. So that's acromial branch. Perfect. So you always see the artery there. Do it with ultrasound. Thanks. Much better with ultrasound than X-ray. So the Max Edmond, the one who published some of the shoulder article, he called me and then asked me for some advice. I told him that it's much better than ultrasound. So, and then I laugh at him. I show one patient I did with ultrasound, and I put the final position, and I looked at X-ray, and I say, did you put it X-ray exactly what I do? Because you don't touch the cortical process. So he always touch a cortical process, which basically is not very exact. Anyway.
Okay, thanks, Professor.
Professor, how often do you do procedures in the anterior branch of axillary nerve?
Okay, good question. So there's a concept. So remember, you always assess the patient with a shoulder. So when you assess, you ask yourself a question. What's the main problem? Is it mainly a rotator cuff disease or a glenohumeral joint disease? Is it mainly a rotator cuff disease and the patient have a solely for superscapular? You don't do the anterior axillary branch. But it's a very advanced rotator cuff disease, then you may actually have to do the anterior axillary. The reason is when you have a very advanced rotator cuff disease, you will involve the long hip bicep. Remember the rotator cuff interval. That is a very painful structure. Long hip bicep is very painful. And there's some branches coming from the anterior branch of axillary. So I will also involve burning the anterior branch of axillary. So I talk about, is it just a rotator cuff disease, mainly supraspinatus, not very major, then I will not. But when it's major rotator cuff disease, especially involving subscapularis and also supraspinatus, I will do anterior branches. And the third category is when they have the exclusively, mainly glenohumeral joint disease, you need to do it. Because when you have glenohumeral joint disease, you have no chance. You have to burn this nerve because this is part of this innervation. Okay, so it's 8 o'clock. So that means it's 9 o'clock in St. Paulo time. That means it's time to have a drink. Yeah, so I'm more than happy to stay a bit longer, but is there any question you want to ask or any burning questions?
Okay, Dr. Peng, thank you very much for your time. and I hope you'll see here in our next meeting. Thank you very much, and good night. Good evening.
Okay, take care, everyone. Okay, bye.
Bye. Tinha mais pergunta, né, gente? Mas o professor já deu aquela encerrada. Pessoal, obrigado aí pela participação. A próxima reunião que a gente tiver aí, vamos estender o convite para vocês todos. E essa aula vai estar disponível amanhã no Caminho Sem Dor, quem quiser vê-la. E, Thalita, eu nunca vi uma reunião terminar desse jeito aí, mas tá bom, né? A pergunta já está na ponta da língua aqui. A gente vai aprendendo, né? Mas perfeito. Obrigado aí, viu, gente, pela participação de todos e saúde. Um abraço. Tchau, tchau.
Obrigado, prof.
Valeu, gente. Um abraço.
Gente, um abraço, boa noite.
Abraço, pessoal. Tchau.